Good morning, everyone. Thank you for joining us today. In these crazy times, we sincerely hope you are all safe and well. My name is Sarah Glenn. I am the Format Plus Chief Operation Officer. Today's event is provided by Format Plus and MediVisum Telehealth and is intended to inform and provide guidance to the attendees around the emerging and expanding topic of telehealth. We're happy to have our subject matter experts today and health IT gurus, Jim Tate and Natalee Scott from MediVisum Telehealth Solutions. Before we get started, there are just a few housekeeping notes that I want to let you all know about. The session today is being recorded. If you have to jump off early or you're joining late or anybody missed it, there will be a recording along with a copy of the slide deck sent via email as a link later on today. Again, we want to thank you so much for attending this event, and I will now turn over the interview to our subject matter experts, Jim and Natalee. Thank you both for presenting.
Thank you, Sarah, and welcome, and thank you to everyone who's on right now and participating in this event. Just a couple quick things as Jim and I get started in terms of the flow of this presentation. So as you can see here, we have outlined the 4 learning objectives, and Jim and I are going to go through a Q&A type of scenario where I will ask Jim some questions and he will obviously kind of fill in with some of the responses to those questions, and we will both kind of have a discussion. So it's a lot more engaging that way, and we can better present, how things and what our experience has been with the specific topics that we raise in each of the questions. So just to go through really quick on the learning objectives. First one would be to understand how telehealth has been impacted by the COVID-19 pandemic. And then we will discuss the benefits of remote care options during and after infectious disease crises. And then review the basic components of telehealth and telemedicine tools and resources. And lastly, we'll consider an action plan for a hybrid telehealth model as part of the ongoing service that healthcare services that providers can deliver to their patients. So just to start very quickly, in the first objective where we talk about, how the pandemic has impacted telehealth, and I think a good place to start would be with the numbers. We've seen from CMS as from March to June, they've estimated the number of telehealth users from March to June to be over 9 million, and that's just Medicare by itself, and that's a jump from 13,000 per week to about 1.7 million at its peak in a week in April. And of those users, 5.8 million of the Medicare beneficiaries were using it specifically for telehealth virtual encounters. Another statistic that might be really helpful in helping to understand how telehealth has grown as a response to the pandemic is that CNBC Forrester Research is estimating an increase of 1 billion virtual health interactions by the end of 2020. So we see a significant usage in virtual health and telehealth, and that is expected to continue even after the pandemic. So now I'm going to jump into the first question with Jim. So Jim, what is telehealth? If you can describe this to us, please.
Sure, Natalee. Good to be with everybody today. And I think what we want to take a look at is, of course, telehealth, the past, the present, and the future. I was involved in the rollout of EMR adoption, and it really took about 5 years to get a shift, a critical mass of providers, ambulatory providers using electronic medical record systems. With this pandemic that came in March and the declaration of emergency, what took place over about 5 years with electronic medical record systems was compressed into maybe just 2 or 3 weeks, as providers had to struggle to find some way to not only deliver healthcare, but to maintain their billing levels at all. And so we'll get into the details of that. But I always like to start with a definition, and always good to get a definition from the Department of Health and Human Services. They give kind of a pretty broad definition here. The use of electronic information and telecommunication technologies to support, promote long-distance clinical health care, patient professional health-related education, and public health and health administration. And so what that boils down to is when we hear the word telehealth, most people think, well, I'm going to talk to my doctor or my provider through my smartphone or through my computer, and we're just going to interact like I do with my Aunt Betty over FaceTime. And in one ways, that is telehealth, but telehealth is definitely a lot more than just that. Typically, telehealth is broken down into 3 different categories. The first, always good to mention, is what's known as store and forward. This is when clinical information is sent for evaluation. This can be vital signs, lab results, radiographic images, patient-generated data. It's where information is gathered, and then either whether it's on some regular basis is forwarded to a provider, or a provider may send it to another provider for review. The second type, and this may actually be the mountain that comes beyond the molehill of the real-time interaction, and this is remote monitoring. This is the use of FDA-approved devices in a home setting to track clinical data on patients, typically with chronic diseases. So if a patient has congestive heart failure, if a patient has diabetes, asthma, whatever they may have, these FDA-approved devices, oximetry for oxygen level, saturation, blood sugar analysis, peak flow meters for asthma, weight scales, blood pressure cuffs, all those can be in a home, and then through either Bluetooth capability or a SIM card, that data can be sent for analysis by electronic systems. And let me just kind of talk about the ways this remote monitoring can be done. And this is an area which hospitals have done for quite some time. We're starting to see it move into the area of clinical practices. If a patient gets discharged from a hospital and they have a diagnosis of congestive heart failure, well, the first data marker that would show that they might be getting into trouble is a sudden weight gain, just because because of their heart failure, fluid is backing up. And so a weight, I'll make up some numbers, a weight gain of maybe 2 or 3 pounds a day, or 5 pounds in 2 days, or however those parameters could be set. As long as the patient stepped on a scale once a day, that information is electronically transmitted to a dashboard, and that dashboard can be configured with algorithms, but that will generate alarms, either texted alarms or visual alarms or whatever. So same thing with peak flow meters, blood pressure cuffs, and things like that. So we're going to see, and we're just starting to see, a giant explosion of remote monitoring. Great way to keep people out of the hospital and monitor them in their home or outside a clinical setting, so that before they get into trouble, there are indications, so some early steps can take place. I kind of mentioned one of the things, real-time interaction. This is what we think about a lot. As a first example, this is if you have a telehealth encounter with your provider. Maybe you've got a rash, or you just want to follow up about something. This would be a good example for those type of clinical encounters. Wouldn't be appropriate for the first time a provider saw a patient, but for follow-up visits, annual wellness visits, which are part of a Medicare care wellness platform, home health. Now, the reason why this could be relative import to home health is there are over 11,000 Medicare certified home health providers in this country, very, very fragmented. And so even with the COVID-19 emergency, there's still a requirement that a certain number of in-person visits must occur that the home health agency to receive reimbursement. There's a certain number of times they have to actually physically see that patient. An example I'll say is, well, maybe they have to see them over a period of time 5 times. But sometimes other events come up and in the care of that home health patient. And if it's necessary to interact with them, and there doesn't need to be a actual physical visit, the visit could be done by telehealth. So that would certainly make it more convenient for the patient, and certainly more convenient and cost saving for the home health agency, not having to send somebody out unless it was absolutely necessary. Certainly hospice for the same reason, rehab, and COVID-19 screening, track and tracing for COVID positive things. So there are really 3 major types. And the one that had to be adopted immediately because the emergency was the real-time interaction. You can go to that next slide. Yeah.
And just to add a little bit of color to that, like one of the things that Jim was mentioning in COVID-19 screening in the current environment, and we know of particular clinics that are using telehealth to support that effort, and not just for screening patients, but also in terms of their outreach to patients, where they may be trapped in their homes or whatever the story is there, and they may have people that are going door to door to check in on some of these patients, and then they're using the telehealth application to call in and follow up with providers who may be in an office somewhere so that they can do the screening. So it could look a number of different ways, and like Jim was suggesting, all of these, beyond just the real-time interaction, all of these other facets of telehealth really opens up the door to what's possible in terms of remote patient care. So then the next question, Jim, functionality, what is the basic functionality for a desired telehealth application?
Yeah, this is a great area that has not been really codified yet, but there are lessons learned and best practices. And so what we're talking about here again is the real-time interaction. We're not talking about remote patient monitoring. We're talking about if a provider needs to have a telehealth encounter with a patient, or a patient schedules one, and the type of functionality that I believe should be in an application. Now, in the early days of electronic medical records, a certification body, CCHIT, arose, and now there are the Office of National Coordinator certifications for electronic health records that stipulate a certain level of standards and requirements to achieve certification standards. We have nothing like that for telehealth. So when the emergency was declared, part of the emergency was that the HIPAA requirements were relaxed, and the government basically said you can use anything you want to communicate with your patients, really anything. And so whether it was FaceTime or any type of text messaging, anything whatsoever could be used, and it could be billed for. So with a HIPAA relaxation, we saw a lot of products being used kind of like a life preserver, but I think pretty quickly the limited functionality, especially in the fact that these are products not created for clinical encounters or clinical documentation, is proven to be a problem as we move forward, more and more of a problem. I think the absolute base we want a telehealth application that is HIPAA compliant. Privacy and security of personal health information is codified under the Office of Civil Rights. It's considered a civil right that your health information is private and secure. That's not required right now, but that relaxation is going to be rolled back before too long. I believe a telehealth application should be web-based, and there should be no app to download. If a patient wants to have a telehealth encounter and they're in a group, maybe they're 60s or 70s or 80s or 90s, to ask them to download an app on their smartphone and configure it is really totally unacceptable. The application has got to be so easy for a patient to use that it can't get in the way or set too high a bar for the exchange of that information during that encounter. And let me just stop here for just a minute and give a personal example. And Natalee, you may have one too. One of my family members had a telehealth encounter recently, and I sat in to watch how it went. And part of what happened was they first had to log into the website or the doctor's patient portal and do a check for their microphone and their speakers and their video. For some percent of the population, certainly not an insignificant, but a significant amount of the population, that's difficult. For a lot of us who live on computers all the time, we're used to doing that. A lot of folks, especially those who are chronically ill, are not used to doing that. So we want the ability for the patients to have the lowest possible threshold to actually get into an encounter. So we want something that's web-based, no app to download. We want patients to receive a link, either a text link or a email link. They click it, and maybe one or two steps later, they're in the encounter. I don't know, Natalee, have you ever had an encounter, and how did it go for you?
Yes, I had one recently, and I think my biggest issue with the encounter, like you're saying, is just, how cumbersome it was to get into the application. And for me, I had the app that I was able to download, and I'm familiar with technology in that way. But I can just imagine, as you're suggesting, for people who may not be as comfortable with technology, having to click around an app and it's, and it's so small and on other stuff, it can be a problem. And I think one of the other things that I encountered with it as well is just the amount of time it took waiting for the actual encounter to begin. And that's not necessarily a technology aspect, but just in terms of a time management instead of the practice. It wasn't the best experience because I don't think they were properly set up for telehealth.
And that's something we'll get to in a few minutes here, really best practices and setting up a telehealth process for a practice. We want an application in which the session is tracked. We want to know that there's documentation in some type of audit log of who the provider was, who the patient was, when the encounter started, and when it stopped. It should have a scheduler. We want to have a provider-facing side of a scheduler, so a provider or somebody in the clinical environment can set a appointment. Also, it'd be really good for a patient to log in, see to a portal or whatever the application is, see an open slot, and schedule themselves in that slot. And as I said, also, we want definitely automated patient reminders, either going out by text or email to the patient. A little plus there is for the ability for those text messages or email reminders to be in the primary preferred language of the patient. If you primarily speak Spanish, we want those reminders to be in Spanish. One thing is critical, and CMS and Medicare says the patient must consent to a telehealth encounter. So there must be some way to capture the patient consent, informed consent. I've seen some telehealth platforms where the provider actually holds up a card and says, "Do you agree to this?" I've seen other ones where the provider reads something and the patient says, "Yes, I agree with that." Um, uh, to me, usually the most efficient way is when a patient logs in, they log into a screen that asks them if they give consent. So we definitely want that. We want for a practice some type of analytics. I think analytics are important. It would be good for just from the back office side of things for whether it's a practice or a hospital to know how many telehealth encounters are occurring and on a day-by-day basis, and also which providers are doing encounters. It's good to get that kind of information. That is tracked for face-to-face encounters. That type of information is also needed from administrative level for telehealth encounters. We definitely want multiple participants in the session. If I was a provider and I'm having a telehealth encounter or doing an annual wellness visit with a patient who maybe is very hard of hearing or has some cognitive issue or whatever it may be, I really want perhaps their adult child who's in another state to be able to join that encounter to provide support and additional information. So you want to make sure there's multiple participants in a session. Absolutely, you want clinical documentation tools. A lot of the products being used now because of the relaxation of HIPAA and reimbursement based on basically anything that you want to use have no ability to clinically document anything. So we want something that has been built from the ground up by healthcare experts for clinician use. Screen image capture. This is important. And I say this because if a patient says, I've got a rash on my leg, it's one thing for them to hold their smartphone up to that rash, but for the provider to see, but it's going to be difficult for most patients to take a picture and then email it to a provider. We want the provider to be able to, on their side of the encounter, click on a button and capture that image, have the provider do that. Screen share and file exchange is important. If I was a provider and I'm reviewing some test results, whether it's a sleep study or an x-ray or whatever, the ability to put that on the screen and show it to a patient is definitely a plus. For telehealth, we want to not only mimic an encounter, a face-to-face encounter, we want to take advantage of the technology to do things that we normally couldn't do in a face-to-face encounter. That's a file exchange. If I have a test result or some educational material, I want to be able to exchange it with the patient, send it to the patient. Likewise, if they have some information they want to send to me, we want that bi-directional exchange. And last, but certainly not least, Natalie, we want an encounter report. A healthcare encounter that is not documented is malpractice. For all practical purposes, considered malpractice. So if the encounter is being documented in the EHR, that's fine. But if it could be documented in the actual telehealth application and a report is generated, that can be the basis for billing or to send to another provider. But just some type of clinical documentation that also targets the patient, the provider, the amount of time, what was discussed, things like that.
Great. Okay, so we know that we have remote patient care now, and we see that it's being adopted more widely, but how do you see it changing the current standards of medicine going forward? And what types of care do you think would be most likely affected with the advent of remote patient care?
I think that's a great question, Ellie. I think one thing we need to be mindful of is that most practices in this country were not doing any type of telehealth encounter technology use. Maybe they were doing messages through a portal from a patient at the most. And so suddenly they were forced into telehealth. You mentioned some statistics at the beginning of our conversation. We know that in March, numerous practices suddenly had to cancel. I mean, nobody wanted to go see their doctor. The doctors didn't want those patients to come in.
Right.
Almost all elective procedures and surgeries across the country were canceled. Laboratories that were doing sleep studies canceled every sleep study. So they went from whatever their throughput of encounters in patients down to zero. So there's a total collapse across the country. And so this technology had to be brought in for a number of reasons. One is to provide healthcare. The other was if these practices were suddenly not generating any reimbursement, but they still had a staff, they still had overhead, it was, from a financial standpoint, threatening, to say the very least. So they were forced into using telehealth across the country. Because of that, and getting over that steep use case of how to use telehealth, where it's appropriate, where it's not appropriate, we're on the other side of that. And so the vast majority of providers who had never used telehealth have now used it. And so I think we're kind of approaching a tipping point here, Natalee, where the decision is going to be made, okay, this works and we know how to kind of use it. What else can we do with telehealth? Mm-hmm. And so that's why I think that since we've kind of crossed that barrier, more practices are going to do the expansion for the remote patient monitoring for chronic care. A lot of these chronic care patients maybe are taken care of by home health entities, but they cannot bill, Medicaid can, state, but at a CMS Medicare level, home health cannot bill for remote patient monitoring, but the providers can. So I think we're going to see more practices using remote patient monitoring just because they're getting more use of the technology. Of course, home health visits, I mentioned diagnostic review. I was talking to a sleep lab the other day, and they're starting to get in the business of doing sleep studies again. And they have the patient come in and maybe do a sleep study, but it's really not necessary for that patient to come back in to go over the results. It can be done by a telehealth visit. The studies and the scans can be shared. And there's, to me, this is a large area, not only for providers, but especially for diagnostic centers, places like the Mayo Clinic, or where there's a need for diagnostic follow-up for disease diagnosis, fertility clinics, genomic institutions, where you need to go over the results, but a patient doesn't need to literally travel hundreds of miles to go over the results. It can be during a telehealth encounter. You can show them all the data. It can be recorded. You can send them the files. Mm-hmm. So I think it's going to be a large increase in that. The remote testing, this is another example of sleep studies. Remote testing can be done really well of a sleep study in somebody's home. CMS has not changed the reimbursement for that. So for those business models that were based on basically in-house sleep studies in a lab, they still have to continue for that. And of course, episodic care. I think practices have started to figure out which patients are appropriate and to do telehealth with, encounters with, and which are not. So
yeah, you know, I read something recently, Jim, as it relates to episodic care in particular. Some 46% of visits that are currently done in office can actually be done via telehealth. Now, that's a significant number. Not obviously, telehealth doesn't replace an in-office visit, but like a follow-up visit or some of these other kinds of encounters that are traditionally done in office can now be assumed using telehealth. And that also, I think, changes the frequency and the availability and all of these other things in terms of how often you get to spend time with your provider. And ultimately, when you talk about remote care management, even patient outcomes are improved with that better connection and more frequent interaction with the provider, no?
That's absolutely true. And I think we're finding out right now, it's kind of anecdotal, hearing people who've had encounters through telehealth, who likes it, who doesn't like it, what works, what doesn't work. We're still in the early stages of ironing out all the wrinkles, and where it's appropriate and where it's not appropriate. But the genie is out of the bottle and it's not going back in. We just need to see how to handle the genie the best we can.
Got it.
It's a giant leap forward.
Yes, yes, yes. Okay, so now, talking about that genie, right? Now that we've established telehealth as, terra nova, so to speak, how do you see it changing, telehealth in particular, changing as we move on past the pandemic?
I think most of this I covered my remarks when we were doing question 3, but definitely, and we're talking post the pandemic.
Yeah.
I think we're going to see a stabilization, and that stabilization will be based on a number of things. It's going to be based on appropriate use cases and also Medicare, Medicaid, and third-party reimbursement. So we'll just see about that. So. Okay.
Yep. And speaking of reimbursement, right? So we're talking about payers like the government, private insurers. Adjustments. What adjustments do you think will become permanent as the current pandemic declines?
You're right, Natalie. This is the billion-dollar question. Mm-hmm. The relaxation of HIPAA and the raising of reimbursement for telehealth to parity to many face-to-face encounters happened very suddenly, as it had to. We were in the middle of a emergency. I can remember, just to give an aside to it, most of the school systems, I guess I'm thinking back, it was either the second or third week in March, on Thursday or Friday, said we're shut down for the rest of the year. And so those school systems literally had 48 hours to figure out how to do some type of virtual education. Very, very similar thing happened with telehealth. Some people in Washington got in a room and said, we're going to raise reimbursement to be equal to face-to-face encounters in many occurrences, not all, but in many. And at the same time, we'll let people use whatever platform they want to just get us through the emergency. And most of that was passed to last as long as the public health emergency was active. And so we're not sure when that public health emergency is going to be declared over. Certainly it's going to be a while longer. And so the question has been, is the reimbursement going to change? Does telehealth work? All those kind of questions. And so right now there is some fascinating, this is at the federal level, at least 4 major bills have been introduced. What these bills are trying to get at is really, how has telehealth helped? What's the value of telehealth? Where should the reimbursement be? So we're still very early in the process because we don't have as much data as we need. But I'm glad to see that this legislation has actually been introduced. None of it's been passed yet, But one thing I was interested to see is earlier this week, the fourth COVID legislation, I think this is called the HEROES Act. I was looking at it hadn't been finalized, but I was looking at the Republicans' draft version, and it includes the continuation of telehealth reimbursement for Medicare through the end of 2021. So that's, well over a year away. So we've been waiting to see some indication. We'll see if that's in the final bill, but I think the level of reimbursement that has been raised is going to be kept up for at least a year, in my guess. And once more of this data comes in, we'll see if it becomes permanent. The HIPAA relaxation, I think, will end before too long. And by that, I mean, it may go into 2021, but, at some point we have to get back to HIPAA protection for personal health information. And I think you've been up on some of the state initiatives you were telling me about.
Yeah. No, one of the things I was tracking is New Hampshire, right? So the governor of New Hampshire, I think it's HB 1623. So he just signed that bill that is requiring Medicaid and private insurers to reimburse telehealth equal in parity with in-person visits, and it's permanently extending telehealth coverage, and he's expanding it also to not just include traditional healthcare visits, but he's talking about behavioral health and care for opioid addiction. So he's even expanding how he envisions telehealth being covered in the state of New Hampshire, and there are a few other states that are looking to do similar things. So even on the federal level, what happens is going to be great. That addresses Medicare primarily, but some states are now enforcing legislation for Medicaid and for private payers as well. So I think from their perspective, some of that, they're appreciating the value that they've already experienced with having this experiment with telehealth that we've had with the COVID-19 pandemic, and they're looking to make it permanent and expand it beyond just what we've been seeing initially.
Yep.
All right, next question. Do you get a follow up, Jim?
No, that was this next one, and this is interesting because whether it's hospitals or private practices, they've literally had years to establish their workflows, how they schedule patients, how they bill, how they receive reimbursement, how they do referrals. And so these processes that, have been refined over years and years, all of a sudden, some new processes had to be developed because of the expansion of telehealth. So I just mentioned a couple of them here. There's got to be, every practice needs to develop some type of process of the data, how that data that's collected during a telehealth encounter gets in the patient record. Now, I've seen this done many different ways. I've seen practices where the provider has maybe two windows on their monitor, or is using two monitors, and one they have a telehealth application. On the other window or monitor, they may have the EHR running and the patient's chart up, and they will document directly into the EHR. But how that data makes it to the patient record is something that has to be worked out. And then that tracking and documentation of data to support the billing codes. There's got to be some record to support billing codes, whether it's third party or government.
Yeah, and I think to the question when I talk about the communication process and even the workflow, I think when we think about telehealth now and how to implement it, you think before the encounter, during the encounter, and after the encounter, and patient communication at each of those stages. Because some of the things that even you were alluding to that earlier, Jim, and that we've experienced on our own, not knowing what to expect during an encounter can make for a very messy experience. So I think, setting things up beforehand with the patient in terms of patient communications, and then setting the expectations while they're in the encounter, also helps to, transition and make for a smoother experience and process inside of telehealth. And then the after, because the other thing that we see or we anticipate is that if the patients aren't having a good experience, and if the workflow inside of the practice isn't seamless, you're going to find people resisting more and more. So I think there's real value in the telehealth experience, but we do now have to start to redesign and reassess our existing processes so that we can integrate telehealth more seamlessly into the work process inside of each practice.
That's a perfect lead into our next question, I think, Natalee.
Yep. The most important elements of the telehealth implementation plan. What are they?
Right, and there certainly could be a lot more bullet points here, but these are just some major ones I think it's important to talk about. There needs to be some type of plan. It can't just go in and start winging this. You can, but it'd be a mess. I think for a practice, it's important to assign a telehealth coordinator. And again, this would be somebody who's familiar with the issues around when to use telehealth, when not use it, make sure that there's a good physical place for a provider to be. I know the ForMed is about to kick off a training program for telehealth skills proficiency that's got some good documentation. It's a good program. And so if somebody's going to be a telehealth coordinator, I would kind of recommend they go through that. But decisions have to be made. Which services can be delivered? Probably don't want to see new patients by telehealth. Probably don't want to see complex situations through telehealth, but there are places where it is appropriate. Reimbursement, there needs to be somebody, ideally that telehealth coordinator, who is probably going to be wearing other hats also, who's familiar with the specifics of the identifiers that must be used to make sure that a telehealth encounter is properly billed and reimbursed. It's got to be a workflow for scheduling. Are you going to let patients schedule? Do you set up a template and only somebody on the clinical side can schedule patients? Those are just things that need to be worked out, part of the process. The path for billing, every encounter, or it's a proper, has the patient received informed consent? Been given informed consent? Is there documentation of the encounter that would support an audit? How is the billing transmitted over to the practice management system? All of this is part of then staff education. So everybody, like right now, in an established practice, knows the rules of the road and how the practice runs and when patients are going to come and how long the average patient is going to take. Most practices don't know that yet, or are learning that about telehealth. So staff education, what can be done, what's appropriate, how billing is going to be handled. And then I mentioned patient education. And by that, I mean is whatever your telehealth services are going to be, you notify your patients that your telehealth services are going to be available, when they may be appropriate, how they'll be scheduled, what type of technology they need to have. So there are a number of things that need to be in that implementation plan.
Yeah, and just to piggyback a little bit on your last comment there, Jim, where you talk about the types of telehealth services that are going to be available. And I think that's key, because I think for all of this to happen, you also have to have clearly established goals in terms of what kind of telehealth your practice will be providing, so that you know what you need to have to address all of these different things that Jim has covered here. So at the end of the day, a practice is a business. And every business needs to have, well-established goals so they know that they're tracking towards those things and understanding exactly what they're able to provide and what they would need to provide those things. So I think the goal piece is also something that you need to consider when you're deciding on what to implement for telehealth. Question number 8. What are important best practices for providers, Jim?
Yeah, as the months go by, this can make this list longer and longer. I think it's important to keep the visit as much like an in-person visit as possible. One thing I'm aware of is in the days of only face-to-face encounters, at a large practice I worked at, sometimes providers would be working with patients and they'd essentially be double booked, or they would get behind. And so there's got to be some type of, in most cases, scheduled time set aside for a provider to have these telehealth encounters with patients. You don't want them doing them maybe in stolen moments in between regular face-to-face encounters. So there's got to be appropriate scheduling. That's just a good work process. There needs to be identified a quiet location with good lighting. We want the patient to be able to see the provider well. We don't want any overhead announcements coming out of speakers that would confuse the patient. You've got to get that, however the software works or whether it's being done manually, we got to obtain that patient's informed consent to a telehealth encounter and confirm that patient's identity. That is, typically done at a face-to-face visit. During an encounter, it's good to have a telehealth platform that either on demand or automatically takes an image of the patient and inserts that into the final report. We got to make sure the patient's equipment is working. Now, this is done a lot of different ways. I've seen automated sessions. I mentioned it earlier, where when you log into a doctor's provider's portal to have a telehealth encounter, there's a automated process that checks out, make sure your speakers are working and your mic's working and your video's working. But there's no point in going forward with a encounter for a provider if the patient's equipment is not working properly. And so I've also seen cases where when an encounter starts, it may not be the provider, it may be a nurse or some other clinical person who's on first with the patient to make sure that all the technology is working in a way that won't encumber the encounter. And then when it's everything is checked off and working properly, then the provider might enter the encounter. We want to make sure that the providers document that visit, including it was a telehealth visit. A lot of doctors' offices may take a quick phone call and talk to a patient or and forget to document that. If it's a telehealth visit, we want to make sure it's documented, both for a complete health record, but also for reimbursement. And again, we want to make sure that they have educated patients on what services are available out there through their telehealth initiative.
Okay, great. And now on the other side, best practices for patients.
This is going to be a training program for all of us. Many of us are used maybe to doing in our businesses WebEx sessions with GoToMeeting or Zoom or whatever we're using. But we didn't often have our video on because we're just like we're doing right now. We're just looking at PowerPoint slides and talking. But once everybody was forced because of COVID to start having these business and also social and community encounters through these Zoom-like meetings, pretty quickly we learned that you don't want to have a bright light in front of you. I mean, you want it in front of you, you don't want it behind you. So you want to be in a quiet location with good lighting. So it's like the whole country has kind of learned how to be more appropriate in how they are viewed and how they can be seen. You want to make sure there's a strong internet signal. Nothing worse than having an encounter when the sound is breaking up or the video won't load. These encounters can happen over a smartphone. I've seen too many encounters where somebody's holding their phone and they're moving around, and it just makes it very difficult for the provider to have a clear, steady view of the patient. A desktop or laptop or is really the best option for patients, but a smartphone will work fine, but it should be kept in some type of steady position. And if a patient has a scheduled encounter for 12 noon, they shouldn't try and log on right at 12 noon, because we've all been through technical problems where something can happen. Your internet's not strong enough, or your speakers are disabled, or you have to give your smartphone permission for the application to use your camera and microphone. So patients should be told to log in early to make sure that everything's been worked out before the scheduled time. And for patients, it's kind of a novel thing to do a telehealth encounter, and it is different from face-to-face. And just like in face-to-face encounters, it's always good to make notes of anything that you might want to discuss with your provider.
Awesome. Okay, and last question. What do you see as improvements to tools and resources connected to telehealth and telemedicine as you look to the future and beyond the pandemic?
Natalee, this reminds me so much of the very early days of electronic medical systems when they were adapted into use. A lot of hospitals had them first, but then when practices started using them, there was no clear standards of what to use, and there were no requirements. There was only best cases and lessons learned and best practices that you only learn from maybe talking to other practices. I remember when the practice I was working with started looking for EHRs, the electronic systems, there was no certification. And so the minimum requirements were not agreed upon. And so even the fact of if a patient record, could two different people access that record simultaneously? There are so many things like that were not automatically part of systems. What type of security? So the one thing we're going to definitely see is improvements in the tools. What we need is telehealth applications that are really built by healthcare experts with a focus on what providers need and want. And so we need those tools that are built specifically for healthcare. The remote patient monitoring, the ability to configure and approve those algorithms that generate those alerts. If you're using some remote patient monitoring software and a patient always runs maybe a little bit high on their blood pressure, and that's normal, and it's okay. You want to make sure that you can individually set alerts and alarms for that hypertensive patient, so that maybe a little bit high blood pressure is normal for them. It's not constantly setting off alarms. So there needs to definitely be work on those algorithms and configuration of alerts. We need, and we're starting to see the expansion of these devices. They have to be FDA approved for remote monitoring. So again, whether it's for monitoring in real time or close to real time blood sugar levels for diabetics, or weight, or blood pressure cuffs, or other devices we've mentioned, we're going to be seeing more of those devices, and the ability of those devices to seamlessly integrate and send that electronic data back to where it can be analyzed in real time. We're definitely going to see more and more of that. And the user interfaces for patient and providers, you know, even electronic medical record systems are still often very clunky, and it takes a while to really learn them. And so we need, for telehealth, the user interfaces for both patient and providers to improve a lot. We want to be able to, for providers to turn off functions that they don't need and are not going to use during encounters to smooth out that interface. For patients, we want to make it as easy for them as possible, to make it as much like they're walking into a doctor's office and sitting down with their doctor. We don't want any of these technological barriers. That's critical.
Okay. Well, Jim, that is the end of our 10 questions. There's so much more we can discuss here, but thank you again for your expertise. As always, I learned something when I'm listening to you, and I hope our audience, our listeners, did as well. Thank you so much, Jim.
Thank you, Natalie, and to everybody else.
Thank you. Sarah, back over to you.
Okay, I want to thank Jim and Natalie so much for your time and expertise today, and to let the attendees know that you will receive a copy of the slide deck as well as a link to the recording later today after we get it loaded. There's in the email, we will also be providing a link with detail regarding our newly accredited self-paced telehealth certificate course, which includes a telehealth practice session sponsored by MediVisum. And MediVisum is also offering event attendees a 20% discount off this new course. And there'll be a discount code as part of the email that you can apply. If you have any additional questions for Jim or Natalie, please feel free to directly email them at the addresses in this deck. And I want to thank you again for participating today, and stay safe. We do have time for a couple of questions, Jim and Natalie, if you want to address those
Sure.
now. I will just read them off, and you guys can speak to them, and the ones we don't get to, we will get answered in writing. Okay, the first one says, do you think primary care will stratify around chronic conditions?
I think that is a question that hasn't been answered yet. A few years ago, CMS created billing codes for reimbursement for chronic care management. And chronic care management, in a lot of ways, the primary care practices were already doing. They're in touch with patients. They have follow-up calls with them. They're well known to a practice because of encounters and communications and prescription refills usually. And so they were doing that kind of chronic care management to begin with. And then CMS agreed to reimburse for what was often already being done. And so that that type of management, again, kind of back office management, nursing contact, things like that over the phone, it was billed somewhere around $45 or $50 a month, something like that. Now, the issue of whether the remote patient monitoring for those patients by practices, it requires another level of monitoring that takes place. And I think practices can do it, can do remote patient monitoring for their telehealth, through telehealth with their chronic patients. But to do it successfully, I think they have to embrace it. They have to be willing to be up to speed on the devices as well as a potential reimbursement, and have somebody monitoring those alerts. Because if you're generating data on those kind of patients, you want to be able to act on anything that falls outside what's considered normal for that patient.
Okay, thank you. I think we'll cover one more, and then we'll let you guys respond to the remainder in writing. This question is, if a covered entity selects a video conference or telehealth provider like Zoom for healthcare, WebEx, Babylon, where patients need to log in and the episode might be recorded or transmitted, are these providers considered as a BAA under HIPAA? And what has been your experience of having the vendor enter into a BAA?
Well, with the relaxation of HIPAA, and I think we're kind of in a gray zone right now. And so I think the BAAs have not been required for them. That's part of the HIPAA relaxation. So somebody could pick up a regular a Zoom account or a FaceTime account and use it for the exchange of healthcare data with a patient. Nothing was required for those third-party entities. However, to me, there's just no doubt that that whole relaxation, its days are numbered. Whether it's going to be 2 more months or 6 more months, at some point that's going to end.
Okay. Thank you guys again so much, Jim and Natalie. This was very informative and interesting to listen to and be a part of. And I want to thank you again for your time. Thank you to all the attendees for your time as well. And be on the lookout for an email later on this afternoon with a link to the deck, as well as a recording of this session. Hope you all stay well, and thank you again.
Thanks so much, Sarah.
Thank you so much, everyone.
Thank you, Natalie.
Thank you, Jim. Thank you, Sarah. Bye.